Okay, I'm sure everyone wants to know, why are we covering intubation? We can already intubate. Yeah, but I want to go over some more particulars, some nuances, and provide somewhat of a refresher. So there is an anatomical airway assessment that should be performed, okay? Although, in the pre-hospital environment, there's often not the ability or capability of performing all of these assessments. So if I am performing a Mallampati on a patient, then that patient means that patient's awake, compliant, able to open their mouth and stick out their tongue, and that's just probably not going to happen most of the time. But something to be concerned about when you're determining if this patient is going to be a difficult intubation, as stated previously, is, are they obese? Do they have a short neck? Can I open their mouth? Can I move their head? Do they have good mobility in their neck? Or do they have a small chin, a small short chin? Or do they have a long elongated chin? Kind of like me. I think I would probably be a good easy intubation. Now, you can also use Cormack-Lehane airway grading, which should be documented and is a good way of documenting how much of the glottis is able to be visualized during your intubation attempt. Now, where grade 1 is ideal, that means that I have a full view of the larynx. I can see the epiglottis, I can see the vocal cords, virtually all of the vocal cords. Grade 2A, now there are two grade 2s, and grade 2A is I can pretty much see half of the glottic inlet. And a 2B is still not bad. So we would actually call a 2B it's not as good as the other grades, but when you're using hyperangulated videolaryngoscopy, a 2 Bravo might sometimes be preferred if you're going for that deliberately restricted view. Obviously, a grade 3 or a 4 is bad. We're not going to attempt to pass even a bougie with a grade 4. Our goal with a grade 4 here is to improve our view, to back out the laryngoscope blade until the epiglottis drops down, and then you can insert the tip of the blade into the vallecula. Grade 3 is one where it's preferred you don't even insert a bougie with that grade. But if you're using a hyperangulated videolaryngoscope and you put that hyperacute bend on it, you could get around that corner. But a 2B is not a bad view. Sorry, 2 Bravo is not a bad view. Something better and something that I like is using a POGO score, which is the percent of glottic opening, which basically you either got a full view of the glottic opening or you got a partial view. So basically you can 100% a full view, and then it shrinks down from there from 0 to 100. Half of that would be 50%, 3/4 of that would be 75%. That's a good way to estimate that. So when it comes to airway assessment, remember again, we have our physiologic criteria, our HOP killers, and then we have our anatomical assessment. Lemon incorporates some of that, but it's probably better if we go with the previous airway assessments. So the Mallampati, the Cormack-Lehane, the POGO score, and our Heaven criteria, and our HOP killers. So HOP killers mostly for determining a physiologically difficult airway, and then the Mallampati, or simply just saying Is their neck mobile? Are they obese? Am I able to open their mouth? Do they have a short neck? That's probably the most practical assessment that we're going to perform. Regardless of your assessment, even if you assess an airway and you think this isn't going to be difficult, 93% of difficult airways are not anticipated to be difficult. And some argue that in EMS, in the pre-hospital world, every airway is a difficult airway. And I think that's probably true. So just assume that this is going to be a difficult airway. Come up with plan A, B, C. Palpate that cricothyroid membrane. Have your cric ready to go. Have your backup airways ready to go. So, ideally, when we're performing intubation, we want first pass success. The number of complications and adverse events increase with each subsequent attempt. The most common adverse event is hypoxia, and with multiple attempts, then that's going to worsen. So desaturation is going to get worse as you progress through numerous attempts. Now, and also, if you make 4 or 5 attempts and you think, I'm going to get it on the 6th attempt, what makes you think that if you didn't get it on the first few attempts that you're magically going to get it on the 6th attempt? All right. Maybe if you're a novice intubator and you've had 1 or 2 attempts, and then a more senior clinician arrives on scene and you want them to make an attempt, that seems pretty reasonable. But thinking that after multiple attempts that something's going to be different, I just don't really buy that. Knowing your airway structures is really important. And I do want to make special mention here when we are intubating. So we scissor the mouth open as we are progressing in with the blade and the laryngoscope. Once we get the tip of that blade seated in the vallecula, our right hand should then come around and feel the thyroid. We're not performing cricoid pressure. Remember, cricoid pressure is out. We're feeling the thyroid because the thyroid here, that big prominent bony structure, is a mobile, maneuverable structure. And when we have the tip of that blade in the vallecula, it's like a lock and a key, with the tip of the blade being the key and our fingers maneuvering the thyroid, the lock. We're manipulating the lock, and you can bring the glottic opening down into your view with that maneuver. So when we're performing our airway kata, it is scissoring the mouth open, inserting the laryngoscope blade, following the curvature of the tongue, trying to look for epiglottis, and then seating the tip of the blade in the vallecula. Once that's seated, bringing my hand around to the thyroid. Airway structures, your glottic anatomy, that's really important to notice. And when we talk about identifying the posterior notch and saying that is all we need to intubate, what we're doing is we're kind of talking about that notch in between the arytenoid cartilage. Now, it's extremely important to know what the airway anatomy looks like and what you're shooting for, and what's anterior or posterior. With video laryngoscopy, it is not acceptable to never use suction. So if you have to go back out to the truck and get suction, and you weren't prepared, that is just not acceptable. If you think you're going to have to secure the airway, have suction ready. It is part of the preparation phase. Have your equipment laid out and ready to go. When I'm performing a DSI or even an RSI, I'm not doing it hastily. I am deliberate. I am methodical. I am having everything ready to go. I'm talking about my hyperangulated 3 blade, maybe a backup blade, maybe a hyperangulated 4 on the average person. If I'm using that hyperangulated blade, I'm going to use a rigid stylet inside of my tube. Now, I would also like to have a bougie as a backup with that hyperangulated bend at the coude tip. I want my cric kit out, ready to go at the patient's chest. My tube holder is going to be around the patient's neck, ready to place on the tube and secure that in place. I also want a size smaller tube than what I'm currently using. So if I'm using an 8.0, I'm going to grab a 7.0. You know, everyone says go bigger if you can. Yeah, but I'm also trying to secure that airway, and it is easier to intubate with to pass a smaller diameter tube than a larger one. So I'm going to have my airway adjuncts in place. OPA on standby, because remember in RSI, sometimes we're beginning with a patient who does have a gag reflex. But if possible, I want an OPA in, and I'm having my suction turned on, tested, and I'm sticking it behind the head of the stretcher so it's easily accessible. So while performing intubation, one person, my partner, is going to be eyes glued to that monitor, and they're calling out SpO2 sats. Now, they're not being aggressive or annoying with it to the point where it's distracting. I want them to call it out as it drops. If I'm at 96, I don't need them to keep saying 96, 96, 96. I want to know as it's going down, and when I'm getting close to 92%, so if I'm at 93, 94%, I need to know that, because if I'm at 93%, I know at less than 92%, once it drops, it's going to drop precipitously. And if I'm struggling to advance that tube and I know I'm at 93%, I might have a higher threshold to say, all right, let's just stop. Let's pull out. Let's reoxygenate this patient and come up with a different strategy. I also want my blood pressure cuff to cycle at every 5 minutes. Now remember, ours default to 5 minutes, so that shouldn't be a problem. The more critical this patient is, the greater the lag in my pulse ox readings. The more critical this patient is, the greater the lag in my pulse ox readings. So when you're looking at an SpO2, you're looking at what has occurred, not what is occurring. Now, the pulse ox, it takes time for what's happening centrally to get to peripherally, and that gap widens the sicker the patient is, and we'll see that here in a few minutes. Now, we're going to rewatch the GlideScope airway training videos. I think they're extremely helpful. As you're watching this, think about the 4-step process. Think about how you can troubleshoot advancing the tube if you get hold up.
The GlideScope hyperangulated blade has a hyperangulated shape relative to a conventional Macintosh shape. The intention of this is to follow the curvature of the tongue around the natural curve, and with less force be able to expose the larynx. Let me explain the rationale for the rightward turn that I make with the rigid stylet. I am following around the curvature of the blade, and if I were just to try to advance this into the trachea, you can see that the rigid stylet and tracheal tube is pointing upward, but the trachea points down. So by changing my grip and coming over the top, that rightward twirl changes the inclination of the tracheal tube. So as I push it down, it is now matching the inclination of the trachea. Let me show you this from a different perspective. The inclination of the trachea is pointing down. The tracheal tube curvature is pointing upward. By rotating the tube to the right, we are changing the inclination of the tracheal tube, and we are also disengaging the tip of the tube, which can catch on the cricoid or tracheal rings, and now the bevel goes up, and it has less mechanical resistance to insert into the trachea. As I pick up our hyperangulated stylet, I want to be conscious about watching the insertion of the stylet under direct vision into the mouth until it becomes visible on the screen. When using a hyperangulated blade with a rigid stylet, on occasion there may be an adequate view, but there may be mechanical problems trying to advance a rigid stylet into proper positioning. A technique that I have found helpful is to take a regular bougie and give it a bit of an upward deflection, just enough so that we can get around the curvature of the tongue. So on insertion of the blade and getting our view again on the monitor, I can now take this bougie, come up over the notch. Now notice the bougie has a small outer diameter. It's only 5 millimeters. Relative to a tracheal tube, which is twice as large, there is improved visualization. There also is a lot of manipulation possible, and it is more forgiving in a tight space. So after I insert into the trachea, and I'm coming around the curve, and I'm in the trachea, and I can feel the tracheal rings, I can rotate it slightly rightward so it fully inserts. I can then bring the bougie over to my left hand, stabilizing it. Now I take the tracheal tube and railroad it over the bougie. And on insertion, as I approach the larynx, I give the tracheal tube a hard left or counterclockwise twirl. I enter the trachea, and now I can stabilize my hand at the right depth, which is 23 in this mannequin. I back out the blade, and I can take out the bougie. When I perform direct laryngoscopy with a Macintosh blade, and I'm going to not look at the monitor at first here, but I go in, I go midline, uvula points to epiglottis, I control the tongue, and now I'm seeing the epiglottis edge, and I'm lowering myself down to get into the line of sight, and I'm reaching around with my right hand and I'm improving my view. At this point, I am actually sighting the target with my right eye only. So there is a very restricted visual access because of direct laryngoscopy. That visual access is created by the small flange of the Mac blade and this restricted mouth opening. So I'm only sighting the target with one eye. If we go up to the video screen, however, now I have both eyes on the monitor, and there's an entire room full of people who have eyes on the monitor. I'm now going to take my straight to cuff styleted tube, and notice the bend angle here is very slight. It's only about 30-35 degrees. This is going to pivot, and it has to pivot into the right corner of the mouth where there is room to pivot backwards. If you pivot this centrally, you're going to hit the central dental arch. So we don't want to do that. So we're introducing the tube, and I come up from below the line of sight. And on the video monitor, this is one of the terrific advantages of using a Macintosh video blade, is you get to see, compared to direct laryngoscopy, you get to see tube placement much better. But what I'm doing is I'm toggling in the right corner where the right dental arch allows me to pivot backwards. So I'm pivoting backwards, and I come up from below, and I watch it go in. I check the depth of placement before removing the blade, and then also before removing the stylet. The tremendous advantage of video laryngoscopy is the visualization of the tracheal tube going through the cords, and the fact that everybody in the room can see that. To me, that is a huge advantage for using video. When using a hyperangulated blade, I find for most adults, the 3 is more than adequate. It is important to appreciate with hyperangulation that if we over-accentuate insertion with the trachea coming down, that our tube delivery gets harder. Sometimes people will take the 4 and over-insert it, and that up-angulation will actually make tube delivery harder. So I just want to compare in this mannequin the two different views afforded by a 3, which I believe works for most adults, and the 4. As we rotate around following the curvature of the blade, I can see the uvula under direct, and then I rotate down. I have seated the tip of the blade in the vallecula. Now I get a view of the target like so. I am leaving the lower half of the screen free for tube delivery, and my view is about 50% of the larynx. This is ideal for tube delivery. We want to avoid this. Now, this 3 is more than adequate to provide an excellent view with enough space for tube delivery. If we switch this out here, and we just take a look now at the 4 in this mannequin, what we're going to see is that after I scissor open the mouth and roll this around, the longer distance between the video element and the tip means we engage the vallecula earlier, and as we come backwards, there is a tendency to over-insert. Now we have a very acute up angle, a very acute approach angle to the trachea, and tube delivery can get harder. So I find in most adults, a 3 works fine. If you use the 4, make sure that you do not over-insert. And for instance, this is more than enough of a view with the 4 to optimize tube delivery without over-angulation relative to the trachea. I want to show you an alternative method of using the rigid hyperangulated stylet. Using the hyperangulated blade and hyperangulated stylet, there is another technique that a single operator can use for easily withdrawing the rigid stylet. You can pick up the stylet holding it up top with a thumb up approach initially, but after insertion, visualization of it in the mouth, coming around the curve and seeing it coming up over the notch, I then rotate my hand, which now is in a thumb up position, my right hand, to a thumb down position. I give the tracheal tube a slight rightward twist while watching that the tip of the tube is still in the larynx, and then my thumb moves back on the tracheal tube, and I can gently rotate out the rigid stylet very easily in one fluid motion.
Okay, so a lot of people might want to know why we're not training as much on direct laryngoscopy or standard laryngoscope blade shape. And I have a good answer. I think it's a good answer. Some people might say, well, what if the video laryngoscope dies? What if the screen goes out or something happens? Well, what happens if the batteries die in your direct scope? What do you do then? Well, you replace the batteries. Okay. Well, you know what? We have generally are going to have more than one video laryngoscope if the supervisors are on scene during an RSI, which they will be. All right. What about skill degradation? If you're using a hyperangulated blade technique, then will your skills degrade with using a standard shape blade? Maybe, but the technique is pretty similar. We're going midline, which we taught with standard laryngoscopy, with direct laryngoscopy. We're going midline. We're seating the tip of the blade in the vallecula. We're doing all of the things pretty similarly. The difference is in the displacement. The hyperangulated blade is not created to displace the tissue, and with a traditional shape blade, you do have to displace the tissue. And we want to use what is most likely to be successful the first time on the first pass. And we do not get enough practice so that we can be experts with all devices. So what happens if something happens and I can't do it with a hyperangulated blade, and then something happens and I don't have the skill to intubate with a Mac 3 style blade? Well, I'm not sure that you won't have the skill. I think you would, but if you're not comfortable using that particular device, then place a supraglottic device or ventilate with the BVM the same way if we couldn't get a tube either way with any device. So let's be really, really good with one device, which I think will be better overall in the grand scheme of things than trying to be really good with a lot of different devices. So the key with video laryngoscopy or any type of intubation is always perform epiglottoscopy. What is epiglottoscopy? It's when I go in to intubate, and my goal is not really to intubate. My goal is not to go into the airway looking for the vocal cords. My goal is to go into the airway looking for the epiglottis. The epiglottis, if you're playing golf, the epiglottis is your flag that shows you where the hole is. If I find the epiglottis and I can see what is anterior to that epiglottis, then I know that the hole that I am going to stick, whatever device I'm sticking in there, is going to be the trachea. And here is, I believe, a good video. This one's not playing, but the image on the left, it looks like there's a hole. Could this be where you need to stick the tube, right? The answer is no, because in the video they slowly back out the blade and then the epiglottis drops down. Then they stick the blade in the vallecula, lift up, and then you see the cords above that. So when someone says, I saw it pass through the cords, my answer is, did you really? If you say you see it pass through the cords, you pass the tube, and then you go to put the end tidal on and you don't have end tidal, chances are you did not see it pass through the cords, but rather something else. So here's another good video about the blade being too deep.
A very common mistake with video laryngoscopy is placing the blade too deep. We see this over and over again with residents and attendings alike. This creates a very steep angle of attack, making passing of the ET tube extremely difficult. Because the airway anatomy is so clearly seen with the video monitor, intubators get lulled into a false sense of security. Maintaining proper blade placement and technique is just as critical with VL as it is with DL. As you can see, sometimes the blade is in so deep that it actually distorts the anatomy of the airway. If you find that your ET tube is hitting inferiorly to the airway over and over again, it is likely that your blade is too deep. Try pulling the blade back out slightly, making sure that the tip is in the vallecula and engaging the hyoepiglottic ligament. You'll find that your angle for tube placement will be more favorable, leading to increased first pass success.
When the blade is too deep and you can see the cricoid ring through the video scope, a lot of people are now calling that Kovac sign because he sort of coined it. And that means that you're going to be passing the tube anterior and the tube's going to be bumping against that cricoid ring, and it's going to be hard to facilitate passage of that tube. What you really want is this view up here on the right where you've got the 50% view to pass the cords and you've got the lower 50% to see for tube delivery. Now you can still get hold up with this view, but the trick is to pop that stylet up good and high and then to do a rotation of that tube to decrease that angle to send it through. So stay high and dry, especially with hyperangulated video laryngoscopy. Now there are two more steps that you can do to try to improve your view. We talked about external laryngeal manipulation. You can also refer to this as burp maneuver, backwards, upwards, rightwards pressure, but external laryngeal manipulation is probably better because I don't necessarily want to do a predefined sequence. Maybe got my tube seating that blade. I'm coming around, I'm feeling the thyroid, and I'm manipulating that to where my view gets better. And another maneuver is HELP, head elevated laryngoscopy positioning. If I've got a poor view where I can't see the posterior notch and I'm like struggling, then I would bring my right hand around to the occiput, lift up until my view gets better. This is generally taught for direct laryngoscopy or for a standard MAC blade. But if nothing's working and you can't improve your view and you're certain that the tip of the blade is seated properly, you can consider these maneuvers. So what do we do on multiple attempts? And a lot of people, I imagine we'll run into this, and I figured some people would have questions about this. So if we've got the patient pre-oxygenated, we've got them positioned, we've got all of our 7 Ps, we've got crew 1 and crew 2, we have induced the patient, we paralyzed them. Now we're going for an attempt. What do we do now if we don't get it? Well, if the sats are dropping below 92% or you back out, you might want to just re-oxygenate. Come up with a new strategy. Do something different. A new operator, a smaller sized endotracheal tube, or maybe the patient wasn't positioned optimally. Maybe I was using a hyperangulated 4 and I need to go to a 3, or I need to go from a 3 to a 4. But we're going to then attempt with a new strategy. Now, each subsequent attempt means that the risk of adverse events is increased. So we want no more than 2 attempts. And then if I'm unsuccessful in that second attempt, or the SpO2 starts to drop again, I'm going to pull out and I'm going to drop supraglottic, an iGel, or I'm going to ventilate with a BVM. What happens if I'm doing that and then the patient continues to spiral, the sats are dropping, they're becoming bradycardic? Well, that's when you would move to a surgical crike. So here's an image of kind of what this looks like. If I make my first attempt and the SpO2 starts to drop, I pull out, I start ventilating with a BVM, and I can't get the SpO2 above 92%. I don't proceed with that second attempt. I do something else. Well, what if I've already paralyzed that patient? Well, you can drop a supraglottic device. You can drop an iGel in a paralyzed patient. They do it all the time in the OR, so I would drop that. See if that works. If it doesn't work, then, and BVM ventilation doesn't work, then I would go to crike. But if I get that SpO2 up and things are working out, then I can make a second attempt. Now, you might be wondering, what happens if the patient loses adequate paralysis while you're preparing for the second attempt? A second dose, a repeat dose of the paralytic may be administered. Although it is not ideal, especially with succinylcholine, to repeat the dose. It is, and I'm hoping that it's not an event that you would encounter, but it is something that you could do with good clinical decision making and with agreement with the group. But it is probably best, if you can help it, to try to manage that patient's airway another way. So between attempts, if we want to reoxygenate, I want to stress that if the patient's paralyzed and you're ventilating him, your BVM ventilation technique has to be darn near perfect. And you might subconsciously think, if I squeeze this BVM faster, then the SpO2 is going to come up quicker. And that is not true. Even if I have a ventilation rate of 10 or even 5, if I'm squeezing that at a very low rate, the time at which the SpO2 goes from 80 to 100 is not significantly different based on the rates. So you do not have to squeeze that BVM quickly. Now, if if the patient has severe metabolic acidosis and I have another reason for increasing that minute volume, I would still do that very carefully, because you have to balance the risk versus the reward of hyperventilation. Something you might also encounter during your intubation is that there's this concept of latency with the pulse oximetry signal, especially using a digital probe. They call them dropouts. These occur pretty frequently. And what happens is, if you're going to intubate a patient and you do so successfully, and then you confirm with end-tidal you got bilateral breath sounds, the sats are still dropping. And you're thinking, what is going on? Again, there's this latency that occurs. Remember, what you're seeing in your pulse oximeter is what has happened, not what is happening or what is going to happen. So you have to be conscientious of this. It is not a cue to squeeze hard or squeeze faster to get the SpO2 up. Maintain normal rhythmic squeezes, especially, if you've got a patient that after intubation has a marginal blood pressure and you start to squeeze that bag vigorously and aggressively, then you could increase that intrathoracic pressure and drop the blood pressure more. So let's talk about a bailout for just a second. A skilled provider uses a BVM to pre-oxygenate. Now, not in all cases, but in most cases it is safe to do so. And if the patient's breathing adequately and you've got the rule of 15s on, you don't have to squeeze unless they have metabolic acidosis. A skilled intubator waits for the SpO2 to get as high as possible before they push the paralytic, or I should say a skilled clinician rather than a skilled intubator. A skilled clinician uses a nasal cannula at 15 or higher for passive oxygenation while you're trying to secure that tube. And a skilled clinician pulls out, has the wherewithal to know that it is less about the patient and more about my ego if I keep trying to get that endotracheal tube if the SpO2 starts dropping below 92%. Now, think about it this way. Patients desaturate at different rates, and you saw that graph. They desaturate at different rates based on obesity, based on what their underlying condition is. So I might have a patient who went from 100 to 94 very slowly. So they're dropping like 1 percentage point every half a second, or every half a minute or a minute. They're very slow. We did a really good job at pre-oxygenating. And then I'm at 94 and I'm like, okay, this patient took a while to desaturate from here to here. So I think I should have time to get from 94 to 92. So I've got time to, continue troubleshooting the passage of this tube. That's not true if the patient's at like 92, 91, 90, because then they're going to desaturate rapidly regardless. And it's obvious that continuous waveform capnography is required to confirm placement and to leave a tube in place, and it's required for ongoing continuous monitoring of that tube. And I'm going to play this video about a case that occurred, and they created a foundation because of this to try to spread awareness of the importance of using continuous waveform capnography and not letting your ego getting in.
All right, what do we got?
All right, 13-year-old male, head injury, transfer to Biden. He's responding to stimulus, light, sound, stuff like that.
He's away.
We need that, guys.
Buddy, relax. Relax, buddy.
Stay still.
Relax.
Stay
It's
still.
okay.
We have to keep him down.
You're okay.
Guys,
You know,
we need to do something
you
now.
don't paralyze him right now.
That, guys.
Buddy, relax.
He's got my hand.
Push it.
Beck is in. He should be relaxing.
There he goes. Okay. There he is.
Bag him.
You ready? I'm ready. All right, let's do it.
I don't think I feel it.
I think it's in. It's in. It's in. Bag him. It's
Give
in.
me a stethoscope.
Here, on me. I got it. You listen. It's in.
Yeah, that's good. Alright, his stats are dropping still.
His heart rate's going down.
What's going on?
I don't know. I'll bag it faster.
Yeah, your tube's good. I mean, there's
I
nothing
saw
wrong.
it's in.
Okay, let's, you know what? That will,
His heart rate's getting low.
yeah, we're gonna do some
His
CPR.
stats are awful.
I know, I'm sure it's all the pressure in his head.
But I saw that tube go in. That tube went in.
I believe that. See, I've given him some epi.
I don't know.
Why don't we call the hospital?
The tube's in.
I mean, he's got, this is like a, he's that B-fib. Let's try some amiodarone.
I don't know. That doesn't look good.
Alright, let's just, I'll call the doctor. Hey, this is the paramedic on our truck. We just left there from the hospital with a 13-year-old male with a head injury en route. He has, he sat up, he extubated himself. We've re-intubated him now, but his sights are dropping, his heart rate's down. We've given him amiodarone, we've given him epi. No, the tube is in.
The tube's in.
No, the respiratory, no.
Tell her the tube's in.
So you heard the providers, they had an affirmative, the tube is in, when it was not. Now, I'm not going to say it's more okay that this happened a long time ago, possibly before the waveform capnography was available, but it's even less okay now because we know better. But they saw it go through the cords. That's the famous last words. And then, but imagine a situation where they said, okay, something's not right. I just did X. I just innovated. Now, Y and Z is occurring. So could it possibly be that the tube, in fact, is not in? So you must have a low threshold. If you don't have waveform capnography and all of the other signs are saying something's not right, then just pull that tube. It is safer for everyone because honestly, if you don't have waveform capnography and you get to the hospital and the hospital checks the tube and they say that that tube's not in, and there's, especially if there's a bad outcome, but even if not, you have no defense. There's no defense strategy for when another clinician says a tube's not in, and you do in the absence of waveform capnography.